So welcome everybody to our session on cancer nanomedicine. To introduce myself shortly, my name is Jan Mollenhauer. I'm professor for molecular oncology at the University of Southern Denmark, and I'm director of a nanomedicine center there. And I'm chairing the session. So I think because we are close to getting started in terms of time, it's my pleasure to welcome the first speaker, which is Professor Simo Schwartz, who will introduce us into personalized cancer medicine.
Thank you very much. It's always a pleasure to be around. I'm going to talk to you about a little bit more of what we have been doing in cancer stem cells. I did a similar talk last year here, also in Clinam. We have been able to go a little bit forward on this, and therefore I will present you our latest data on that. So for those of you who doesn't know it, cancer stem cells are subgroups of cells that you might find within the tumors, and they are the ones responsible of the tumor growth, development, and also the ones that might survive if they get detached, and therefore the ones responsible for metastatic spread of the disease. No? And this is because these cells have the capability of surviving if they get detached, and this is very important, because the fact that they detach and survive is due to the fact that they have different molecular pathways activated than tumor cells themselves. So if those cells here, which are also tumor cells but not cancer stem cells, they detach, they die. Many people think that tumor cells will have an unlimited number of divisions, and that's not true. So most of these cells will keep going on, and they will divide. Of course, they have more capabilities than normal cells and healthy cells, no? But at some point they die. So if we can get rid of these cancer stem cells, the idea is that tumors will as well get cured. Actually, these cells, if you take them, and we did this as you see here, and you isolate cancer stem cells and you introduce them into mice, they will develop tumors. And this is something that is quite characteristic of these cells, because if you take the tumor cells, which are not cancer stem cells, and you do the same thing, you do not get tumors or metastases like you see here. No? Those are cancer stem cells in which we have introduced bioluminescent vectors so we can track them down, and what you see here are metastases. Now, this is not happening with non-cancer stem cells. So those are the target cells that we want to treat. Of course, most treatments doesn't kill them, so it means that although we're seeing shrinkages of the tumors, at some point they regrowth and reconstitute the tumor or give metastasis, so you have recurrence. The idea is that by targeting these cells, we will be able to block the tumors from recurrence. This might explain why when we see these nice survival curves, and we see that most treatments actually delay a little bit more the death of the patient and increase the survival, at some point it's a little bit disappointing, because we all see that they go down and down, so at some point everybody dies anyway. No? Of course, it's not the same thing to die a month later than 5 years later, no? But anyway, it means that at some point people die anyway. So, and this is probably due, and I say probably because we don't know for sure, but it's probably due to recurrence and to the fact that most tumors become resistant to treatment. No? Probably this is also some of the questions that are behind the fact that these cancer stem cells might become at some point eventually resistant to treatment. No? So fortunately, the cancer stem cells have some surface receptors which might identify them. And this is useful, because if we want to think about targeting, then we can take a look at some of them and try to develop nanoconjugates directed against those targets. So CD44 is one of them, and we have been working with this quite for a few years already. And it's interesting for us because it's a receptor that you might find in head and neck cancer, but also in other cancer types like breast, pancreatic tumors and prostate. So if you have a nanoconjugate against this receptor, then it might be useful also for other indications, not just for one. No? So we have also developed a system that allows us to track down these cancer stem cells because we can monitor them, and therefore we can use them to monitor these treatments and to try new nanoconjugates. If you isolate these cancer stem cells, you will see that most of them contain these receptors like CD44 receptor. In this case, this is a breast cancer cell line, and other ones like aldehyde 1, which is quite characteristic of these cells, and also some others like OC4, CXCR1, and also genes that are related to the epithelial mesenchymal transition like vimentin or twist, no? With strong reductions of the cadherin. So this is what you would expect from a cancer stem cell. Right? They are more metastatic, they are more independent in growing, they are more they have survival to non-attachment, and they can actually spread. So with this idea, we identified that in breast cancer cell lines, and I'm taking this as an example, these cancer stem cells, which are those ones here, tomatoes because they're red, so we identify them like this. They overexpress CD44 and other receptors like EGF receptor and also SPARC. And that's interesting because we have a paper published very recently, I'm not bringing data on that, but showing that the expression of SPARC seems to be important on the fact that it somehow helps cancer stem cells to survive and to metastasize. So if you block the expression of SPARC in cancer stem cells, then it is much more difficult for the tumor to grow and to give metastasis, although we don't know yet exactly why, the reason for this occurring. So we tested the idea of targeting, I think I'm running out of of targeting cancer stem cells by using specific receptors against EGF receptor, the epidermal factor receptor. We have one which is being used in the clinics, which is cetuximab. This is per se a treatment, or against CD44, and also compare it with Abrexan, for instance, which is a non-targeted disease, also being loaded with paclitaxel. And this idea was because SPARC was also present on those cancer stem cells. So we did PLGA PEG nanoparticles, in which we loaded also paclitaxel and CD44 antibodies or cetuximab. And here what you see is an example of how the fact that some of these nanoparticles contain receptor antibodies against the CD44 receptor makes them much more attractive in terms of internalizing those nanomedicines. So this is what you see here in red is the number of cells that get the nanoparticles internalized because they have the CD44 antibody, which is much higher than those ones do not having this receptor. So nanoparticles really internalize much faster if they have this antibody. Okay. And we know also that this antibody makes the nanoparticles not just internalize faster, but also to remain much more time within the cell than if they don't have this antibody. Okay. In this case, we compare all these nanoparticles with Abrexan, with paclitaxel, with non-loaded nanoparticles like those ones here, like PLGA PEG, like PLGA PEG with cetuximab, PLGA PEG with CD44, Abrexan, this is paclitaxel, and this is the combinations with antibodies and paclitaxel. No? So what you see here is that this here is paclitaxel, this black here is Abrexan, and these two here are the PLGA PEG PTX nanoparticles with the specific antibodies. So what you can see is that those nanoparticles are also effective, perhaps not as much. They don't have as much potency as Abrexan, but they are actually. Do we have another one? Do we have another one because it's not working? Yeah, just to show it, because I don't know if it's me or. Well, I keep going. So those particles here with the antibodies, thanks. Those particles here with the antibodies, they work nicely too. And one thing that was very interesting is that besides having efficacy in the tumor cell line, the tumors, if you check them for the proportion of cancer stem cells, what you see is that the number of cancer stem cells, which is always a very small proportion of cells, a small percentage of cells on the tumor, they are quite resistant. So when you treat them with paclitaxel or with Abrexan, they increase the percentage. This was kind of expected because we knew that if you treat tumors, most likely cancer stem cells will be resistant, so the percentage goes up if you check them later, post-treatment. No? But we thought that nanoparticles somehow were going to be able to overrun this resistance. No? And that was kind of a big idea, the big hypothesis that was on the field. No? So if you use nanoparticles, then you will probably avoid some of the mechanisms of resistance of these cancer stem cells, and this will help to gain sensitivity. So what we're seeing is that that's not happening with nanoparticles, at least with those ones. I'm not saying that this is happening for all of them, but we're not seeing this happening when using Abrexan or when using the PLGI paclitaxel. So they goes up anyway. So it means that we are not getting more sensitivity on cancer stem cells as we had expected before. So the theory doesn't really fit here. But on the other hand, what we're seeing is that when we use targeted nanoparticles, then we have this reduction. Well, it's not as big as we would like to, but there's a strong reduction anyway. So at least a 30% of reduction in this resistance might be attributed to the fact that we are adding these targeting systems. No? And we use these systems without paclitaxel, nothing happens. So it means that active targeting, at least in this cell, which is MCF7, it's doing something just because of this targeting. This reduction is not seen with cetuximab because it's not significant. But the reason why we're not seeing this with cetuximab is because even though cancer stem cells from breast have a little bit higher levels of EGF receptor than non-cancer stem cells, these levels are very weak compared to CD44. So that might explain this. No? In fact, with that idea, we check other cell lines like colon, for instance. This is colorectal cancer cell lines. Those cell lines are cell lines with different expression levels of EGF receptor. No? So if you check these efficacy studies here in vitro, what you will see is that in these two cases here, in which the levels are quite low, well, they're not low, but not as high as in HCT8. The systems work, or those ones here, this is paclitaxel. Systems work nicely, this is paclitaxel. But you don't see differences between the fact that they have the cetuximab or not on the nanoparticle. But if you go into a cell line in which, like this one, HCT8, the level of EGF receptor is high, then you see the differences between the targeted and non-targeted nanoparticles. So in this case, this nanoparticle, which is targeted against cetuximab, it works much better than the ones that doesn't have to. And same thing if you go to cancer stem cells. So if you check in this cell line, in the HCT116 cell line, we check this one here, because it has the lowest level of EGF receptor of all of them. So we want to be sure that even small differences in EGF receptor might mean something in terms of treatments with this targeted nanoconjugate. So we check this cell line and we check the level of expression of EGF receptor in cancer stem cells and non-cancer stem cells. They're pretty much the same. So we're talking about a cell line that has low levels of EGF receptor, although those levels, as I said, are much higher than you would expect in breast. But no difference between cancer stem cells and non-cancer stem cells. However, if you check whether these systems work and work nicely in cancer stem cells, what you will see is that the level of drug that you need for treating cancer stem cells in red versus non-cancer stem cells in blue is lower when you use cetuximab. So it means that cetuximab targeted nanoparticles work much better over cancer stem cells than if you use non-targeted or paclitaxel on these cancer stem cells. So active targeting is again doing something in these cells. Okay, so with the idea of trying to find out what kind of targets we might also use for targeting cancer stem cells, we have two options. One is to work with surface receptors like EGF receptor, like CD44 receptors, and obviously we have to find much more other receptors because those receptors are not exclusive of cancer cells or cancer stem cells, so you might have also some toxicity associated issues. No? So with the idea of if we have to target cells of this kind, so we can do it in two ways. One is targeting the receptors, the other one is targeting specific pathways. And as I was saying, there are specific pathways that seems to be involved in cancer stem cells. I'm sure that John will talk about that later. So we compare our non-cancer stem cells with cancer stem cells. We did some omics like everybody else and get a list of genes, and from that select some of them just to be able to design specific nanoparticles against those pathways. So in that sense, these are some of the data that we got. No? So besides, in red are the ones that you will find in cancer stem cells, in blue in non-cancer stem cells. So besides some of them that will get kind of expected, like snails, for instance, or TGF-beta, which are genes that are more related to stemness and cancer stem cells, we find this, which is ALOX5, that was extremely well overexpressed and in a very consistent manner in all the cancer stem cells that we have checked. This is just an example on breast, but this is also found in other ones. Not in all of them, but in many of them. So what's ALOX5? ALOX5 is the enzyme which is responsible of transforming arachidonic acid into leukotrienes and is involved in inflammation processes. No? But we know that ALOX5, if you check in tumors, almost 80% of tumors from ovary, breast, a little bit less in lung and cancer, they overexpress pretty much ALOX5. No? And lately it has been related, ALOX5, not just to this pathway, but also to other pathways like EGR receptor, Wnt pathways. Those are stemness pathways related to colorectal cancer, for instance. And we know that its inhibition increases E-cadherin and cell death. And this is something that, if you recall one of the markers that I show you, cancer stem cells have very low levels of E-cadherin because they survive to non-attachment. So it has been proved lately that if you working with Xyloton is a marketed inhibitor of 5-LOX, which is being used in asthma, for instance, asthma patients. It has been tried in other models like leukemic cells and prostate cancer very recently, and it has been proved to be good for treatment, and they reduce metastasis in vivo. So we have tried this in our models just to see if we can get a proof of concept that some drugs might be much more effective on cancer stem cells than others just because they target a specific pathways. No? And this is what you see here when we compare paclitaxel and Abraxane again and with Xyloton. So here we have the same thing. So Abraxane and paclitaxel, as we saw before, they increase the level of cancer stem cells, so they increase that percentage because they're not so efficient, although they are very good drugs. They're not so efficient on cancer stem cells than on non-cancer stem cells, and Xyloton reduces this resistance. So it seems that knocking down that pathway might work. No? So now we're working in see how we can manage to work with Xyloton or with new small molecules that we are developing against this pathway. The reason why we're not using Xyloton is because they have very high needs in terms of the amount of drug that need to be effective. So probably Xyloton is not the best one to be used for this, but it's a nice proof of concept. So what this, to me, perhaps the message that I would like to send you is that I remember a few years ago that we were dealing with the idea of talking about active targeting, and the idea was we need to have some active targeting, so in a way that we will be able to bring more drugs and more nanoconjugates to the tumor tissues. No? And this is not happening, unfortunately. So most of the active systems that are being tested, they fail. I mean, we don't have more drug on the tumor tissue. It seems that there's no way to overcome the efficacy of the APR effect. No, but at some point, perhaps we have to rethought this in another way and think that active targeting might not be useful just for, and we'll see if nobody else comes with some good idea just to fix this, but it might not be useful at this point just to increase the level of drug in the tumor, but it might be very useful in terms of avoiding cancer stem cells from growing up, or at least to reduce the resistance. And this is very important, because at some point when you see those survival curves at some point going down and killing the patients, most of it is because these cells survive and they give recurrence and resistance. So killing them from the beginning is crucial. Yes. So that's all about it. Thanks. Thank you. This is yours.
Okay, thanks a lot for this nice introduction. Yes, it's mine. For the nice introduction into cancer stem cells, also very, very useful for my talk, I have to say, later on. Other questions from the audience? Kenneth, please.
Are the cancer stem cells accessible in the tissue in the same, or are you going to face the same kinds of problems as we face in general about penetrability and things like that?
Well, what we see is that at least in vitro, the internalization goes much faster.
Sorry, I meant in tissue.
In tissue? Yeah. We don't know yet. We don't know yet. The problem is that when you use cancer stem cell models and you go to in vitro, they reproduce the tumor as it is. So at some point, the only way you have to see if the treatment is effective is not just by seeing that these nanoconjugates internalize in vivo in cancer stem cells, but in particular because you reduce the number of metastases. And this, we have some preliminary data showing that that's happening, but still, we're not 100% sure yet. Yeah.
I think you touched an important point. You may expect them to be sitting in hypoxic niches. And that is in fact a kind of drawback, because it would not be highly vascularized, meaning that it is one dimension more difficult to target a drug to that.
So you're back to the same problem of penetrability and accessibility as we are in general?
It might happen, but I would expect that to happen much more, and that's my feeling, in tumor tissues, because they're big. Perhaps the vessels didn't really go inside the tumor, so it's more on the outside of the tumor, the ones that get more nanoconjugates, and you might have a necrosis and an oxypar fit inside. No? But in terms of survival, what you want to target is metastasis, in fact. So I'm not worried about the primary tumor, because it doesn't kill the patient. It's just cut off in most of the cases. When you can actually surgically remove the tumor, then that's not a big deal in general terms. But metastases are, so probably micrometastases will escape from this because they don't have neovessels. But macrometastases, meaning not something like this, but a little bit more than the micrometastases, there is the cancer stem cell, and you have a neovessel. So in that case, I think that we will be able to combat metastases, and that should be an improvement. Yeah. We hope.
Yes, please.
Yes, generally micrometastases are formed from the cancer stem cells. So what you're suggesting is basically to prevent the metastasis. Do you want to use it as a preventive medicine? Because you are suggesting to use highly cytotoxic drugs, and which are usually are not used for prevention, right?
Well, if you use a genotoxic drug, probably, and most of the drugs that we have in the market, most cancer cells are quite resistant, but not to all of them. For instance, in the case of Xylodone, it works much better. Probably it's not the best one because of the pharmacokinetics that it has, but salinomycin, for instance, in cancer stem cells is like 100 times more powerful than PDX, like paclitaxel. So I'm not saying that this will prevent metastasis from appearing, because I'm not sure that we will be able to kill cancer stem cells on the tumor side. But those metastases are arising in other places. And for that, we know that cancer stem cells are capable of preparing the niches for metastasis sites in other places, no? But then they have to go there and to attach there and to grow there and give you the metastasis and start the neovascularization process. So in that place is when we might have an opportunity to kill them,
so
even if it's some of them.
Second question, thank you very much for that. Second question is, CD44, for example, is the antigen which is presented on many cells, including blood cells.
Right.
So if you're thinking of injecting the nanomedicine to
I'm not thinking about injecting that. And that's not the idea of this talk. I'm not saying that we have to do nanoconjugates against CD44. I'm saying that this is a good proof of concept that active targeting on cancer stem cell might work. The problem is that we need to find receptors which are not as wide.
Which are not yet
everywhere.
Found, basically.
Not yet.
Yeah,
well, we have some of them, but we're still trying.
Or we may need drugs that only kill the cancer stem cells and not the normal cells.
That's the other option. That's the other thing.
Thank you
For
very
instance, some of the drugs, let me add something to that. Some of the drugs that we have tested, drugs that are capable of inhibiting some molecular addition pathways, no? And those drugs seems to work much better with cancer stem cells than with normal tissues. And this is because normally cancer cells and cancer stem cells, they develop a very strong dependency of very specific pathways involved in addition. And this is not happening on healthy tissues. So they're more resistant to those treatments, the healthy tissues.
Thank you.
Okay, I think we should proceed in this session. Thanks again, Simo.